Bringing this all together, I'll start with you, Rick, but we really can get everyone's opinion on this. What advice would you give to providers or your colleagues about how to treat opioid-induced constipation moving forward at this time?
Right, so I think several components. The first thing I tell them is ask the questions, right? I think while the people at this table is sort of preaching to the choir, so to speak, is an old saying, but it is true still, I think, from surveys we've done that all of our colleagues aren't asking those questions. So you have to first we have to all do a better job of identifying patients in need. And I think once then, I think we do have a reasonably well-structured algorithm to approach. I think to what we've heard from Brett and others is you don't need to get stuck, so to speak, in the OTCs or other, sort of lifestyle things for so long if they're not responsive to that, to move more quickly in that context. And I think a little bit for both providers and for pharmacies is I've had patients come back and say, hey, the pharmacist told me I can't take the OTC drug with the Pamora, so there has to be education a little bit to pharmacists that these drugs are compatible, they work differently that way. Similarly, I think what we've already heard, we have to make sure the patients take the drugs as prescribed, that they don't double up, that they don't take them PRN and things of that nature. So I think making sure the providers know how to dose. I think to Jeff's point, if they do get side effects, at least some of them, they can back down on the dose. Most of them, they can back down on dose. Those type of things are important.
Would anyone else like to offer some thoughts?
Yeah, my three simple answers are, first of all, an ounce of prevention is worth 6 pounds of cure. That's number one. Number two, opiate-induced constipation is not a diagnosis to jump to. It's a diagnosis that has to be worked up to, particularly in the emergency department and in the palliative care or cancer patient, to make sure you're not dealing with something else like obstruction. And then finally, and it's as we all said, that being on an opioid and being aware of it is important as a provider, but that's a conversation starter, not a conversation stopper.
I would add, too, that being on opioids in and of itself is stigmatic. And in this era of the opioid crisis that we talk about, maybe it's more of a polypharmacy crisis. We have to keep the patient in the forefront and know that they're afraid to ask many questions secondary to opioids if they are on them and on them appropriately. So we have to allow the conversation to happen.
I think I'll leave some room for closing remarks, but this has been an extremely informative session. Before we end this discussion, I'd like to get final thoughts from each of our panelists, and thank you all very much for your expertise today. Let me start with you, Dr. Stephen Anderson.
I think I already said it. Ounce versus pound. Don't jump to the diagnosis, and conversation starters, not conversation stop.
And Teresa Malik-Searle from Stanford.
Yeah, for me, it's really normalizing the discussion, giving the patient permission to ask the questions that they have, educating the patient as well as educating our colleagues about the problem, being able to diagnose the problem, and a prescription and treatment plan for opiate-induced constipation needs to be first and foremost while you're writing that first opiate prescription.
Jeff, do you have any thoughts for your pharmacy provider colleagues out there?
Yes, I would like to sort of give a shout out to those pharmacists that are working in the community setting and suggest and encourage them to do an entire profile review to make sure, even though a patient has opioid-induced constipation, look at the entire profile. See how we can take a polypharmaceutical regimen and rationalize it, how we might be able to eliminate certain drugs. Brett talked about reducing opioid doses, that people are kind of encouraging that. And if that can't be done, I think a rational approach to that would be maybe not reducing the dose, but changing to another opioid and reducing the dose for cross-tolerance so that the analgesia is not compromised. The patient still gets an analgesic benefit, but the opioid load is reduced. These are all things that pharmacists can be very much involved with. Simple phone call.
And as we've seen, it certainly takes a village to take care of these patients, make sure that we're identifying the issue, having the conversations, prescribing these new agents, these PMORs, when the time is right, and then trying to push the envelope and doing better for each of them.
And I think also not feeling like you, the clinician, the emergency room doctor, the nurse practitioner in the office, the nurse practitioner in the hospital, have to work in a silo and have all the information. Feel comfortable reaching out to your colleagues to have the discussion. Use your pharmacy staff. That's what they're there for. They're there to help you. They're there to help you take care of the patient better. Ultimately, it's the patient experience. So don't feel fearful about reaching out to others for help.
Absolutely, I couldn't agree more. All right. Well, thank you all very much for your expertise and contribution to this discussion. On behalf of our panel, we thank all of you for joining us, and we hope you found this peer exchange discussion to be useful and informative.